Ken, your presentation highlighted an increasing focus in national policy on quality. How is this changing the way that clinical commissioning groups will commission compared to practice-based commissioning or primary care trusts?
The most important element is that there is a real focus and continues to be an increased focus on quality. One of the advantages clinical commissioning groups have is that they should have a clear understanding of the major quality issues, and having established them they could really focus on them and put in mechanisms to ensure quality is guaranteed for the population they serve.
Mm. In your area in outer northeast London, the PCTs in that area were some of the first in the country to structure practice-based commissioning around localities. What did you learn through that process that will serve you well for clinical commissioning groups?
I think localities are very important because one of the areas we'll be able to focus on is localities collaborating to make a strategic difference. Often acute trusts provide services for a large area, and it's important that PCTs, clinical commissioning groups, work together. And what we've done, and our focus on quality, have been all clinical commissioning groups and all PCTs in the area focusing on the unified goals of improving quality. And that's made a big difference, and we're all united, and that leadership, or joint leadership, is really very important.
Yeah. We heard from Judith Smith's presentation this morning that if you look at the lessons from practice-based commissioning and the different ways in which clinicians have been involved in commissioning to date, they were quite good at improving primary care, quite good at improving intermediate care, less good at challenging hospital care. From your experience, can you tell us a bit about how local doctors are challenging hospitals in your area?
Yeah, I mean, one of the key elements of that is local doctors, through their day-to-day contacts with their patients, become aware of the quality issues. So whether it's emergency medicine, a particular speciality, maternity care, they become aware of it. Then the second thing is that they are aware of the mechanisms that can be put into place. So they would involve everything from contracting levers to actually putting in specific incentives and penalties into contracts, and following that through clinical governance mechanisms. One of the advantages that clinicians have, they can actually gather a lot more what we call soft intelligence. Yes. And they can actually get involved in discussions and actually get involved in clinician-to-clinician discussion and almost put in improvements before it becomes, is highlighted as a very significant issue. And therefore it's marrying up what they see with their face-to-face contact with patients and putting in the strategic and the contractual and the levers in place to ensure quality is guaranteed and having real accountability of that.
You've got a real case study that you're presenting. Could you tell about poor quality and how this the commissioners are starting to tackle that? Could you tell us a bit about, from a commissioning perspective, what's being done?
Yes, I mean, one of the areas that we've tackled locally is maternity services, and we became aware of the issues around maternity through different channels, and that's what often happens in quality, whether it's patient feedback, whether it's clinician feedback, whether it's significant events, and often they all point to the same direction. What we've done is, one, made it an absolute priority, so we've got a specific commissioner for maternity. Secondly, we've got the Quality and Safety Committee that very much prioritises it, and we've got a specific work plan on this. And what we've done is looked at what the specific issues are and said that, look, in order for us to be assured that quality is improved, we would like to monitor these particular areas and we would like to monitor the action plan. And we've been very focused on that and very determined in discussions all the way. And we're very pleased that we've had executive and chief executive buy-in and the boards buy into this. And we've been very closely monitoring it, all the activity and quality, sometimes weekly, sometimes 2 weekly basis, to ensure that we're making progress. So, you know, we know from sort of week-to-week basis what difference has been making. For example, the number of women in the maternity unit and how quickly they've been assessed. These are key quality indicators, and we know whether that's happening at the right level or not. And if it is happening at the right level, the quality is improving, the risk is much less. If it's not, then we can raise concerns very quickly. So I think if we looked at our plan, I think there'll be no doubt that the commissioners have a grip on it, and I think that's what it really illustrates. So one can make a difference, but one's got to prioritise and put the resources in.
From your experience, do you think that the grip of the commissioners in that situation has made a difference?
Oh, absolutely. We were very clear from the beginning that maternity was a significant issue, it was a significant quality issue, and it definitely needed addressing, and it was it was a very high priority. And we put a lot of resources in, and the Acute Trust, absolutely no doubt that this is the area we need to focus on, but also to do it in a structured way that it is very clear what the assurance is required, and that expertise is also required. So rather than saying one's generally improving quality, what tells you that quality isn't getting better?
You mentioned you've got to have the resource to put into these issues, to put the time and effort in to turn them around. But we know that clinical commissioning groups are going to have less management resources to spend than their primary care trust colleagues. Is that realistic?
Yeah, I mean, with the resources clinical commissioning groups have, that they will be responsible for the strategy, and they will have to prioritise their resources. And clearly, providing safe and effective services is high priority, is one of their key responsibilities. And therefore, I think resources would have to be prioritised where there's a risk to patient quality, particularly to patient safety. And therefore, yes, there are going to be lots of calls on resources, but this is an area that I don't think we can compromise on.
We haven't heard very much today about the NHS Commissioning Board, but obviously got a key role in supporting clinical commissioning groups. What would you expect from them to support you in delivering commissioning quality and effective care for local people?
Yeah. I mean, I think, I'm sure the National Commissioning Board would prioritise quality, but also I think they would have an understanding of quality in the strategic area and the quality in the health economy. And clearly, with the influence the National Commissioning Board would have across the health system, particularly acute trusts, I think they can provide this joint focus approach to make sure change happens. What we don't want in a situation is that clinical commissioning groups trying to tackle it and they're impeded in their approach because they haven't got the level of influence. So the National Commissioning Board and the clinical commissioning groups acting together to address serious issues is what we need. And I think that joint approach, I think, will make a big difference. And that's really what we'll find, that we need influence at the highest level to make a difference, because of the kind of change we're trying to make.
And particularly in those sorts of situations where a hospital services might be commissioned by more than one commissioning group.
Absolutely, and I suppose ensuring that clinical commissioning groups are acting in a unified way is absolutely critical.
Ken, thank you very much for sharing your experiences today.
Sure.
It's been fascinating.
Welcome.
Thank you.